like a lot of benefits professionals, we become known as problem solvers in organizations. And that was my reputation back when I was working my way up to the financial side of the house. So the one of the numbers I complained about quite a bit was our health and welfare spend when I was doing labor analytics, and it was a number that kept going up every year, and nobody seemed to be too worried about it. So, well, somebody needs to be looking at this number.
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits to save lives, save dollars, and save your talent. Welcome back to Broken Benefits, everyone. Really excited to introduce you all to Rich Krutsch today as our guest. Rich used to run a major health plan for a leading logistics company. And with many thousands of lives and tens of millions or over 100 million in annual budget, he helped to keep flat trend for the better part of a decade, and ran some of the most innovative strategies in procurement, in vendor management, and analytics that I've seen of any benefits manager anywhere in the country. We're in for a real treat. Rich, thanks so much for joining the show today.
Thanks for having me, Lee. Excited to be here.
Yeah. So to start off, would love to hear a little bit about your background and some of the health plans that you helped to run.
Obviously, I came up through finance. So my confession is that I'm not a lifelong benefits person, but I think that was really helpful because I learned the language of business and was able to translate that into what I ended up with in the benefits world. My end role in the logistics company was over people services. I was the vice president of people services there, where we really touched all facets of the employee life cycle, from compensation, payroll, HR, analytics, and everything else. So, from the health and well-being perspective, what was unique is that we serve as our own TPA, and so we were processing our own claims, and we didn't do that because it was a cool thing to do. It's because we could do it more cost effectively than other people that we benchmarked against the other options out there in the market. But what that gave us is really good data to look at. And when I moved into this role, it was like a treasure trove of data, really. You had all the data you needed to really start building some exciting things, and that's what we did. We built a descriptive, predictive, and probably the best thing that we did was built a prescriptive engine that helped people understand what was the next best thing that they could do. Moved on from there to a consulting group, Stevens Inc., where I led strategy on the life and health side, and started kind of creating the same thing again because it worked so well at ArcBest. Besides just flat trend, we had created a couple of years of really significant negative trend. So we had several 100,000 lives there. Then moved over here where I am today at where we touch about 3 million lives. So I continue to expand, but I think the philosophy is pretty much the same. How do we apply the insights and really work on that gap between insights and results?
Everyone, now just a quick word from today's sponsor.
Lemonade for 50 cents. It's for a good cause.
This situation seems terrible, right? Well, what if I told you it actually happened in the United States in 2021? These are the families of people who work for companies just like yours. Give your employees 100% medical coverage with Catalyze Health.
I love that. Now, your approach to analytics when you were sitting in that role, running benefits for the employer, your approach to analytics is really unique. I haven't seen its equivalent anywhere else. Would you mind telling the story of how that happened? How did you end up in that role and sort of evolve into the way that you ran the analytics while you were there?
Well, I think like a lot of benefits professionals, we become known as problem solvers in organizations. And that was my reputation back when I was working my way up to the financial side of the house.
Mhm.
So one of the numbers I complained about quite a bit was our health and welfare spend when I was doing labor analytics. And it was a number that kept going up every year, and nobody seemed to be too worried about it. So, well, somebody needs to be looking at this number. And, I think it was described as one of our CFOs told us that it's a plug number.
Yeah.
And just plug it into your analytics model and go on. And so in around 2010, 2011, got a call from our CHRO and CHRO and CEO. And they said, "You remember that number you were worried about?" And they said, "Well, now we're worried about it too."
Okay.
Said, "We need you to do something about it." And like I said, I didn't have a background in benefits. So I went and tried to find people that were really smart in this field and doing some kind of cutting edge work. Ended up with D. Eddington at the University of Michigan.
Yeah.
And read his first book, Zero Trends. I hope everybody's read that. Then later on, he read Shared Value, Shared Results, which I think is really the best piece he did. But after the first book and talking with him, we went back. We started putting in biometrics and starting to set the stage for some basic well-being things, and went back to talk to him. And that's, I think, the most typical thing anyone has ever told me about benefits. He mentioned in his office. Was going back and I was explaining everything we were doing, the numbers we were seeing. Well, we thought, and we were still increasing at an increasing rate, but maybe not quite as fast.
Right.
And I thought he was going to pat me on the head, say, "Good job, you're on the right path." And he kind of said, "Listen to me," didn't say a word, right? And he finally rocked back in his chair and he said, "Well, congratulations. All you've done is sped up people's entry point into the healthcare supply chain." And that, takes all the wind out of your sails, right?
I can imagine. Yeah. That's like a kick in the stomach. Thanks a lot.
But on the flight back to Arkansas from Michigan, it dawned on me that that's exactly what we had done, and that we really needed to take an optimization approach to how we deliver benefits in a data-driven way. So that's what really started the ROI thesis on how we approached analytics. We had used a lot of different analytics vendors out there, and there are a lot of good ones that are good at population health. But
Sure.
the real change in healthcare happens on an individual level. You can do the lag measurement with population health metrics, but the change happens one by one out there.
Yeah. So now explain it to me just in really, really simple terms. What was the approach that you were having on how you were thinking about analytics? And then after that flight, after that interview, what changed that led you into the new model, and what was the new approach?
Well, the new approach was really, you had to figure out what it meant to win here. And that's another thing that Dee and then later Tom Emmerich really drove home for me, is that, if you don't know what the end game is here, then it's going to be really hard for you to get there. Right.
Totally.
So we developed it, this kind of KPIs around, and I think most employers that I've worked with are somewhere on this continuum between attraction, retention, engagement, and cost containment.
Right.
Some lean farther one way than the other, but they're all somewhere on that spectrum. And I think
right.
the metrics that are important to your organization really depend on where you are on that spectrum.
Okay.
So, for us, it was, how do we make sure that we've got the right talent in the organization, that they're engaged in a thriving population, and do that cost effectively with, we had metrics around trend, we had metrics around care gaps, we had metrics around care defects, as well as our engagement numbers. And we had those weighted as to which were most important.
Did you generate these kind of internally yourselves, or did you hire doctors or bioinformatics people? Like, how was your approach there?
No, we did it ourselves because I think it's important for each organization to really wrestle that question to the ground themselves. You can have people that help once you get that figured out as to what's important come up with how you actually calculate them. And we had some really smart people in analytics that were part of our team that did that for us. But the actual metrics we came up with were ours. Yeah.
Wow. And so then you identified what it is to win, and you identified the KPIs that get around that, around engagement levels, overall trend, risk, and cost. Then what did you do, and how did analytics help? How did the analytics that measure these things help drive a change in those outcomes?
I think, and there's a lot of discussion around different types of analytics, but we really used all three. We used descriptive to measure what we were doing.
Okay.
And how it was working. We used predictive to see what was coming, right? And I think, there's this, we are really focused on layering primary, secondary, and tertiary prevention methodologies appropriately in our population.
Okay.
Right. And we use the predictive analytics to really understand how our layering was working, right? Were we getting the right solutions to the right people at the right time? Then the prescriptive piece was actually the delivery of those solutions, right? Based on someone's risk profile, what is the right course of action that person can take? So, we look at things from an efficiency and effectiveness and experience perspective.
Okay.
Efficiency is, are your solutions out there creating value for the members of your population based on the clinical outcomes that you've hired them to perform and achieve? 2, are they effective at what they're doing? Are they actually achieving those results? And 3, is their experience good enough that people actually want to use them?
Okay, so now walk me through a simple example of a descriptive measure, a predictive measure that leads to a prescriptive action on one or two of the most important areas.
Yeah. Well, one of the things that we really decided to focus on was metabolic syndrome.
Okay.
Metabolic syndrome is a precursor for a lot of disease states.
Yeah.
And if you think about that progression from, the normal progression of disease is from zero disease, pre-disease, actual disease, right? And, with metabolic syndrome, you're talking about cardiovascular risk, diabetic risk.
That's right.
Musculoskeletal risk, a lot of different things.
Yeah. Kidney, if you live long enough, all of it.
Yeah. It all starts to come into play. So, what we wanted to do is understand as those people moved across that threshold from non-disease state to pre-disease state, were we catching those people and were we introducing them to the right solution that gave them the opportunity to reduce their risk back to zero disease state? Because, if you leave that unchecked, what happens is those people eventually migrate up to full disease state, right?
Right.
And then if you're focused on that tertiary prevention methodology in the actual disease state, that continuously backfills. So, early on, what we did is we focused in that tertiary space where a lot of solutions are, but we found that you really couldn't get ahead there because you were backfilling as quickly as you were making headway.
Yeah, as soon as you get somebody stable, they're immediately replaced.
They're replaced by somebody else.
Right. Okay, so you were addressing both. So people who had hypertension, diabetes, et cetera. And then you were going upstream to find those who are just right on the verge. And then did you use point solutions for that, or in-house capabilities, or plan design? How did you make a difference? Because conventionally, most people I think would say, you can't make somebody quit drinking Mountain Dew, right? You're not going to fix that. Maybe you can make insulin a little cheaper, or have a nurse calling to make sure people are taking it or whatever. But I mean, it's changing behavior on a whole population is really hard. So walk us through how you broke that mold.
Well, one of the things that we learned from Tom Emmerich, and he was the previous Walmart exec.
That's right.
Is the importance of removing friction from your benefits ecosystem. He came and actually to my team taught a class in Lean Six Sigma that applied to benefits. So every time you had someone in a queue, every time you had somebody waiting for something, that was waste from a lean perspective. So we really attacked those delay points so that the experience was better, and people wanted to adopt whatever program it was. For metabolic syndrome, it was a group. It really depended on how the level of risk that person had. If they were just tipping into risk, we had a point solution that was primarily weight loss, mindful eating, but also attacked some of the behavioral health components of that, as well as the medication management around, hypertension or hypolipidemia.
Right.
But, as the risk increased, we had virtual primary care, we had on-site clinics, it depended on where that person fell in that risk spectrum. But,
Okay.
Just as people were just tipping in, we typically went to that mindful eating weight loss program to see if we couldn't arrest the risk right there.
Okay. So you would deploy programs through a number of different channels to try and get to people who are early risk, as well as those who are already there. And how do you know if you were successful? How did you measure and track that?
That's where the descriptive analytics come into play, right?
Okay.
Understanding, are the people with hypertension controlled? Are you making an impact to hypolipidemia, A1C levels? Are they being checked, and are they controlled or uncontrolled?
Okay.
Those are all the kind of the static measurements we looked at to make sure that we were performing. And then obviously, what was the cost of doing that? Were we cost effective in how we were deploying those resources?
Would you collect EMRs or like lab results data? Most employers, I don't think, usually get that.
We didn't get EMRs. I would have loved to,
Okay.
but we did get lab results. So we
Yeah.
had that as benchmark data for us.
Okay, so you were able to see lab results, et cetera. I'm guessing you found that it was working, at least some of them. And what was the overall impact that came out on the other end of that?
Well, we found that the people that went through the program were about 11 to 14% less expensive than a risk matched cohort that didn't go through the program, right? And that carried forward in time. And we tended to see an increase in that cost savings over time instead of it reverting back to norm. So once those people went through the program, and some people went through the program twice, and we were okay with that. But
Okay.
that made a difference long-term, longitudinally in that person's health.
Wow. And what answer would you give? I speak to a lot of people who say, "Hey, Lee, predictive analytics are silly. Just because we know some people are going to be having are getting more sick. A few of them will take care of themselves, but the rest, there's nothing you can do about it," which may or may not be true. But what would be a good answer to that?
Well, I think again, it depends on your purpose, right? And I think if you got the right data sets, you can be fairly accurate with predictive analytics. We were predicting at 3, 6, 9, 12, and just a little beyond that, because that's where we tried to match up with the business reporting cycles. And
Okay.
we also wanted, as you go farther out, obviously the accuracy of your predictions starts breaking down because of all the reasons you mentioned. It gets a little blocky out there on the edges. But as long as you are stayed focused on what's actionable right now, regardless of the risk profile, it could be low risk or high risk people, you can be fairly accurate in your predictions.
Yeah. I can imagine a lot of people listening might feel a little overwhelmed with trying to create a whole new analytics array, especially if they don't have an analytics background. But even if they do, healthcare is big and complicated. What are some really simple baby steps that even a smaller, under-resourced plan could take?
Yeah. Well, I think the first thing is you got to get your data. Mike Adams and I are kindred spirits in that you got to own your data. It's yours. Whatever you need to do to get it. There are people out there that can help you get that data, find them and get your data, understand what's going on.
Wow.
Secondly, I think, you got to look beyond just typical healthcare data points. I think there's other things that impact that data. We've talked about social determinants, that can be a factor. What people do and how they do it, when they do it, from a work perspective, like if someone's working the the mid shift during the day, it really blocks them from a lot of the brick and mortar healthcare options or opportunities that are out there for them. So you got to have other options for those people. So I really understand what's going on with individuals. With your data is important. So getting that data all in one place is critical. After that, I think there are a lot of things that we learned that I think can be applied to whatever size group you're talking about. One thing that came out is the correlation to risk for people that are investing in their 401k or getting periodic dental cleaning, right? We say, well, what does that have to do with health risk? And I think what the data told us is that people with longer term perspectives tend to take better care of their health, right? So what we can do as benefits leaders is help people have longer term perspectives, right? So when we did our 401k meetings, which was also part of my group, we always talked about, said, we don't want you just saving up for your first big medical bill once you retire. We want you to enjoy your retirement. So let's also think about how we can improve your health here and set some goals for that, so that when you get to retirement, you can actually use your 401k for some things you really want to do, what's important to you.
Everyone, now just a quick word from today's sponsor.
The Lockbox is a place where all of our customers' healthcare benefits data is brought together into a single location that allows us to then extract insight and have repeatable value built on top of it. There's so many different pieces of information that are floating around out there that it can be hard to know what's the important elements to pay attention to and what's the underlying noise that's in the data. So what I think we do that's really critical is we help bring our expertise and our experience in modeling to help our customers understand where the real value is that enables them to make the best decision for their member population that they support. For the first time, there's a commonly understood, centrally located data model that all of your different data sources can live, and that you are able to trust the quality of, to trust the security of, and ultimately to trust the insights that you're going to get out of the data that you have.
Really interesting. So what was the connection there? So if I've got it right, if people have longer term perspective, they're going to take better care of their health. They're going to be more productive at work. They're probably going to be more retentive, et cetera. And so one way to encourage longer term thinking is with the 401k. And so you would do communications and encourage people to participate in the 401k as a mental shift strategy. What was the piece on periodic dental cleaning?
Well, I think, periodic dental was very similar, and
Yeah.
I think you could probably see some of the same results with eye exams as well. They're kind of voluntary, but it's all about people thinking about what's down the road, right? And how do I, with periodic dental exams, I think it's really interesting because it's kind of pain avoidance, right? Do you want to wait? Do you have dental pain, or do you want to take care of it now today with a simple cleaning?
Yep.
Yep. And
Totally.
I think that follows through with healthcare, right? That is it worth doing some preventive things for your health that's going to keep you from having a bigger issue down the road, right?
So now let's say we have this data, and I have 10,000 employees, and I know which ones are investing in the 401ks and which ones have zonked it out. And I know which people are getting preventative, dental visits and which ones are not. Now, what do I do with that?
Well, you can take that information. It's really the ones that aren't doing that you're interested in.
Okay.
Right. So you want to understand one, why they're not doing it. We operated on-site clinics, and the question that most clinics ask when you walk in the door is, how are you doing today? Right. That's when the nurse is doing the intake, that's what they ask. Right. And the number one answer, over 90% of the time, we track this too, was
fine. Yeah, I'm either fine or I'm dead. Those are like the two acceptable answers.
Right. So I think changing just simple things like changing that question to what are you struggling with today?
Oh, you're breaking frame on that. Okay.
Because
And
that opens
yeah,
the door to really understand what's going on with that individual. Because you can promote. There's a lot of ways to promote 401k participation or deal cleanings. Make
sure.
sure that everybody understands that. You can send the postcards to people's houses so the spouses get the information too. But really understanding what people are struggling with opens the door to a conversation that you can have about how you can help someone.
Wow.
And that gives you information that is really, really valuable.
And so in your clinics, would you speak to the providers about, hey, encourage people to maybe participate in the 401k, ask them if they're getting their dental cleaning and vision appropriately, stuff like that?
Our clinic providers understood everything that we offered from a benefits perspective so that they could help connect, and they could absolutely connect people right back over to our team as well if they found a need.
The most fascinating anecdote that I've heard in the last month was I was listening to a researcher in longevity, and he said that one of the highest correlation items for people who live a really long time that isn't just, like a Blue Zones thing or eating Mediterranean was flossing. Flossing has a super high level of correlation with extreme longevity with people. And immediately the researcher said, just please note, we do not believe that flossing extends your life. We notice that people who are so careful about their health that they will even floss, which no one has been making you do that since you were 6 or 10 or whatever it was, right? But if you're actually a person who is doing that, then you're the type of person who's doing 100 other things that will probably disproportionately allow you to live a longer life. This absolutely raised the bell on that. That's so fun.
Today's conversation with Rich Krutsch continues on the next episode of Broken Benefits.
Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.